which is encountered in the ICU and frequently asymptomatic and associated with increased mortality. The topics covered today are cellular physiology and metabolism, relevance in the ICU, clinical features, and the treatment. Now, coming to the cellular physiology, it is a divalent cation which is predominantly present in the intracellular compartment, that is 99%, and it is the second most abundant intracellular cation after potassium, which plays an important role in the cellular metabolism and hemostasis. At the cellular level, magnesium influences membrane function by regulating ion transport. It is required for NAK ATPase activity, which maintains the transmembrane gradient for sodium and potassium. Magnesium also regulates intracellular calcium flux by competing for calcium binding sites and influencing intracellular calcium transport. It is an essential cofactor for most ATP requiring processes and also useful for DNA synthesis, in activation of gene transcription, initiation of protein synthesis, and regulation of energy metabolism. Total body calcium is roughly around 20 to 28 gram, which is distributed majorly in the bones, around 50%, followed by muscles, soft tissues, and blood. The normal concentration of total magnesium in serum is 1.5 to 2.3 milligram per deciliter. Now, coming to the prevalence and the relevance in the ICU, the reported prevalence of hypomagnesemia in adult intensive care ICU ranges from 15 to 60%, most commonly associated with liver transplantation and in patients with severe sepsis. And now coming to the etiology, the most important causes are the decreased GI intake due to magnesium poor diet or TPN or malabsorption syndrome or short bowel syndrome, which is or due to increased GI losses due to chronic diarrhea, intestinal and biliary fistula, nasogastric suctioning and vomiting, intrinsic renal losses due to interstitial nephropathy, post-renal transplantation, post-obstructive kidney injury or diuresis, and drug-induced renal losses due to loop and thiazide diuretics, aminoglycosides, amphotericin B, cyclosporine, cisplatin, granulocyte colony stimulating factor. And there are other endocrine and metabolic causes like hyperaldosteronism, hyperparathyroidism, hyperthyroidism, SIADH, diabetic and ketoacidosis, hypophosphatemia, hypercalcemia, and hypoalbuminemia. And distribution of magnesium in acute pancreatitis, administration of epinephrine, insulin refeeding syndrome, massive blood transfusion, and other causes could be due to severe burns. Now, coming to the clinical features, first, cardiovascular, we encounter atrial fibrillation or flutter, VT, supraventricular tachycardia, ECG changes, which is usually similar to hypokalemia, like flattened T waves, presence of U wave, and a prolonged QT interval, and hypertension and risk of digitalis toxicity. Now, magnesium is a cofactor for NAK ATPase in the cardiac tissues, so it is associated with a variety of dysrhythmias, and the major reason for the cardiovascular symptoms does involve NAK ATPase activity. And other are neurological, like seizures, nystagmus, delirium, coma, and muscle fasciculations, since it produces a depressant effect on the nervous system through its ability to cause presynaptic inhibitions. It also depresses the seizure threshold by its ability to competitively inhibit NMDA receptors. The neurological and neuromuscular manifestations of hypomagnesemia include coma, seizure, weakness, and signs of muscular irritability. And the supplementation of magnesium might provide neuroprotective properties in patients with traumatic brain injury and prevent cerebral vasospasm in patients with aneurysmal subarachnoid hemorrhage. It is also used commonly in pregnant patients with preeclampsia or eclampsia. It is also used to treat bronchospasm in patients with asthma. Now, coming to the treatment. First, the management of hypomagnesemia should include the identification and correction of the underlying causes and replacement of magnesium. And in general, we give magnesium in symptomatic critically ill patients, and it is usually administered intravenously at magnesium sulfate, that is 1 gram equals to 4 millimole, or magnesium chloride, that is 1 gram equal to 4.4 millimole, and also used orally as magnesium gluconate. And for urgent treatment of hypomagnesemia, an intravenous bolus of 8 to 12 millimole of magnesium, that is 2 to 3 gram, followed by an infusion of 40 millimole